Colleagues, thank you from my side as the chairperson of the simulation interest group for U21 Health Sciences. I want to say a warm welcome to all of you. Obviously, I'm speaking from South Africa, and it's in the middle of the morning, about 10:30 or so. And I know for some of you, you would be watching this afterwards, but I also want to say a great big thank you to the hosts for getting up so early and for organizing all of this and making sure the technology is working. It's been a very interesting time for all of us, I think. And I think especially for the simulation learning group, we've been quite active since our last meeting. And this is a simulation interest group, let's call it that, which is, I think, one of the more active groups. We do engage with each other between meetings, and we make some good friendships, and we welcome anyone who's watching to please feel free to drop me an email or contact us. We really are an open group, and we like to have as many people participate as possible. For this session today, I won't take that much more of your time. We're going to have 3 people presenting some of the work that's come as a result of the collaboration of the simulation interest group. And the 3 presentations will take us through some of the projects that have been initiated. Some of them have had some seed funding from U21, which we're very thankful for. And then I think after each of the presentations, there may be a minute or two, if there are anyone who is online at the moment who has a question or a query. We will deal with it after the presentation. And then at the end, I will have a short discussion, and I might invite some of the presenters to speak about the way forward leading up to our next interaction. But without further ado, everyone, you're all very welcome. I'm going to then hand over to Allison Mandrusiak, who will talk to us a little bit about the production of the videos and that project that we've just finished. Allison, over to you.
Wonderful. Thank you, Craig. And hello, everyone. Hi from Australia. I'm from the University of Queensland. So it's quite late in the evening here. So it's great to be joining with you around the world. So what I thought I'd do is I'd actually share with you some of the innovative ways that I've come up with to be able to deliver and engage with students in simulation remotely. I will, as part of this, touch on some of the U21 funded resources that our collaboration has developed. But I'm hopeful that even if there's just one tip or trick that you're able to take away from this that might help with your strategies for simulation during these very uncertain times with the COVID pandemic. So I'll be looking at what I've called synchronized simming. So this is basically zooming students from home into the sim ward. So from the room or the classroom to the Zoom at home, or from the bedside to the website, and utilizing technology as our friend. So as you know, simulation typically happens in dedicated and bespoke simulation spaces. On campus, we do this at UQ in our simulation ward for physiotherapy and other health sciences. Of course, when COVID came, that disrupted our plans, and we found ourselves needing to simulate in the home of our students and our staff. And how could we then connect our students and our staff together for simulation in this brave new environment? So I did some reading, and I found that others had been looking at telesimulation. However, this was mostly looking at how we could just zoom simulation into the home, and therefore students really were just watching the simulation unfold, and mostly were not able to participate with any hands-on interaction from the home. So I thought there must be some ways that we can look creatively and how we can still continue to engage students from the home. So I then read with glee that there has been a bit of work in low-cost simulations, and I thought low cost doesn't mean low value, and therefore I started to look around my own home at what types of props and equipment I had within the home that students would have that would then enable them to continue to participate in simulation. And this isn't something new. For many years, we've been creative and looking at, for example, this epidural model using low cost or no cost items from around the home or that are readily accessible. And more recently, and this is not UQ, but a shout out to another university where students were at home practicing with bananas and chicken legs, performing various simulation or medical procedures like cannulation or suturing. So I then started to think, okay, what have I got around the home to create a torso and a body for students to be able to do the cardiorespiratory simulations? So I found what makes a really good thorax is basically a pillow with a wire coat hanger and a shirt, which we'll look at in the coming slides. And then for some techniques, we also need the lower limbs. So there you can see the equipment that I set out for the students to collect from around their home. So in order to create that thorax, you can see the wire coat hanger there fashioned into a sternum and the ribs. So we get the subcostal angle and we get the sternum with the xiphoid manubrium, which then creates some anatomical landmarks for us to do some cardiorespiratory techniques. And then as soon as you add a shirt onto a pillow, you instantly then get the other surface anatomy, for example, the clavicle, the axilla. Great if there's some arms as well for some of the techniques, but really this gives all of the parts that we required for our most of our techniques in our simulations. Of course, the lower limbs then you can see again using things from around the home, towels, tracksuit pants to create the legs, and then the feet with just some socks stuffed inside other socks. And that could help then to create our pillow patient, which we affectionately called it. And you can see here that the students really got on board and those at home created their pillow patient. So we had a whole virtual simulation ward full of pillow patients. And this then enabled the students to practice the techniques that are required in our field. So for example, palpation, auscultation using the landmarks, things like supported cough, and it's mainly around the positioning, the instructions to the patient, the psychomotor skills, so the handling, the verbalizing the steps and the procedures. And not only that, then the students in the home environment, but then actually synchronized with those students who were able to be on campus, learning alongside those who were offshore, whether they were international and not able to return or arrive in Queensland due to our closed borders, or whether these students were in hotel quarantine awaiting arrival or interstate with our locked borders, all sorts of situations where we could have students at home learning in real time in our simulations with those students on campus. And you can see some of those parallel activities happening, and also using other strategies for some digital tools to help those students at home to be able to virtually and utilize these electronic tools to be able to engage with the respiratory techniques. So again, some of the more specialized equipment, not all students have a stethoscope at home, but we found that most had these sort of older style of earphones. So again, it was really about positioning their patient to be able to perform the techniques and the manual handling and the instructions that are required. Where we have specialized respiratory equipment. So I was able to create some H5P, which is an online interactive learning objects tool, really simple to use. And I was able to then create some basic activities like this drag and drop, where students at home needed to select the appropriate devices or parts of the device, and then drag that to assemble in the order that they would assemble that device in real time. So just some examples of how to take those specialized equipment into the home in a virtual way. Of course, we utilize the students who are on campus in a wonderful peer-assisted learning model, whereby the students at home would be learning from our little trolley here with the iPad alongside their peers on campus, who were really embracing in terms of providing great instructions and explanation of particular respiratory techniques and devices to their peers, so that students could feel a sense of belonging to the campus and the space. So even when they were learning from home, simple strategies such as performing mini welcome videos from the space and welcoming the students to the space and familiarizing them with the simulation ward, even though they're offshore. And I created, again, using that H5P tool, a virtual simulation ward tour. So students could actually move in real time around this space and clicking on these little hyper buttons here to get some information about the space. Just again, that familiarization and that sense of connectedness to the space, even though they were learning from afar. The U21 funding has been invaluable in creating a suite of videos, and in this instance, the simulation in the cardiorespiratory physio space. And you can see just two snippets of some of those videos for students, again, offshore, being able to cover those specialized simulation techniques in a vicarious way by watching these techniques. And we found that these have really expedited the students' ability once they do arrive on shore to be able to perform those techniques, having been so immersed and seen those so clearly. So as you would all do in your simulations, the wonderful thing about the resources that we've developed for our patient cases is that they are digital. So these could easily be shared with students offshore. And then those students who are onshore talking through the case prior to seeing their patient, we then zoomed those students offshore into that discussion. So they felt like they were part of that preparation before seeing their patient at home or their pillow patient. And again, utilizing technology. So here is our Zoom live streaming those students and educators in the sim ward to the home. And again, you can see the student in the ward and me then providing feedback to at the same time in a synchronous way, the students in the ward and those who are at home or in hotel quarantine or whatever their location might have been at that time. We also used these sorts of hybrid approaches whereby we would have the standardized patient through an iPad interacting then with those students who are offshore. So again, just another strategy for that synchronized simming from the bedside to the website. So making technology to be our friend. So I'll finish up then just with a thought that really struck me. We've been talking a lot about hybrid models, so utilising on campus and online and this sort of synchronised simming with pillow patients and being quite creative. And I was speaking with one of my chemistry colleagues at UQ who mentioned that the term hybrid is talking about when there are several different parts that are combined to make a new thing. And I thought, well, actually, although I'm not a chemist by background, I think that this is somewhat aligns with what I've been doing, which is taking several parts, bits around the home that students have, adding those together to create something new, which was then enabling our students to participate in these virtual simulations, as you can see here. And it really struck me when I received feedback from the students how valuable and really game-changing these experiences have been. So particularly these interactive simulations, although it could appear almost quite whimsical with students using pillows at home and creatively turning couches into clinics and pillows into patients. It really struck me that that connection with the students and that continued engagement, the feedback, the online activities really help students to feel connected and actually cared for throughout what otherwise could be a fairly bumpy experience for them as they've navigated through all of the challenges with COVID. So I think something that's so simple has actually been so valuable and indeed quite game changers, as I said, for many of these students. So I will stop there and I'll pass to Craig, but thank you so much for your time and very happy to take questions now, or my email is there for anybody who's watching along via video. Thank you, Craig.
Thank you, Allison. And I must just say, I think one of the things that I've reflected on when I watched the slides and the work you've done is, I think it's almost a theme that has come through for all of us as educators, and it's the idea that we try not to leave any student behind. And you know, I think you've really embraced that, and I commend you for that. You know, I know it will never be the same being at home as if you were in the sim lab, but the reality is if you're an exchange student or you got stuck in transit or you got kept at home or you were in quarantine, you are left behind unless educators like yourself take the time and the effort to include you. So aside from all the wonderful techniques and the great tracksuit pants and the pillows, I think that it's more about showing you your caring as an educator to try to keep including those students. And I know in our country, in South Africa, one of the big challenges is, of course, not just the interest of the educator to keep students engaged, but also their ability to connect and to have data and the quality of connection. But well done for that. I must say, my own technology is not that good. I see there's 15 participants. I don't know if anyone does have another follow-up question quickly. I think we do have time for one. Karien, did you want to ask something?
Yes, thank you, Prof. Allison, just quickly, the tool that you used, because you said it quite quickly, so I missed it, to do the virtual tour as well as the drag and drop type questions. Would you just repeat the name of the tool, please?
Thanks, Karien. It's H5P, which is a fairly undescript or nondescript name for a really jazzy and simple to use tool. No, I have no commission or endorsement with the H5P company, but I found it to be really user friendly. So I believe if you have a Google of that, I know UQ does have a subscription or whatever the agreement is, but it's worthwhile looking into for some really simple strategies that are really effective. But thank you for the question.
Awesome, thank you.
Thanks. Okay, well, I think, look, Allison, your details are available on the network, and I'm sure there may be others that see the recording that would also want to contact you. But thank you very much. A wonderful presentation and good work that's been done. Let's then move on to who's next in our line. It's Karien. Can you hear me? Sorry, my sound.
Yes, I hear.
Your picture froze on my side for a second. Okay, Karien, we can see you. Over to you.
Okay, let me quickly share my screen. Please tell me if you can see. I'm sure that you can.
Yes.
All right, so thank you. Thank you for having me, everyone. My name is Dr. Karien Henrico, and I'm from the University of Johannesburg. So we are in sunny South Africa, and I think we probably have the best time to do the presentations today, so I'm not complaining. So I was asked just to give some feedback on a project that's actually been, well, the simulation grouping has actually been busy with this project for some time. And I'm very excited that we are close to the end of the project and our enrollments will start pretty soon. Let me just see. Is my screen now not moving? Ach, nee. Let's try this again. Right, there we go. So it's moving, I'm assuming. Okay. So for the last few years, we have been busy with a postgraduate diploma in clinical simulation. This was quite a mammoth task, and with some seed funding from U21, which we are forever grateful for, we managed to get a collaborative core curriculum together that we presented in Glasgow, but we'll talk about that a little bit later. So I'm just here to quickly take you through the program and the modules that we have prepared that we'll start enrolling pretty soon. All right, so just quickly background. So as you can see that this project has been going for quite some time. So in 2016, there was a need identified for simulation educators. 2017, the simulation grouping compiled the assessment guide that I have there on the side of the screen. And then 2018, it was decided to constitute a task team that will start with the core curriculum. And then, as I mentioned, 2019, we received funding from U21. So we were an international collaborative team from Birmingham, South Africa, and Queensland that worked together on the core curriculum. So let me just quickly see if I can move. Yes, I can move this. All right, so the purpose of this diploma is basically to develop health professional educators who are skilled in the integration and application of clinical simulation. So it's not just the application thereof, but it's a holistic approach to simulation. And I think as soon as you get to understand the pedagogy and the underpinnings of simulation, it's much easier to move your simulation onto an online like Allison does. And when she spoke, I could actually see that she understands the underpinning of simulation, and therefore it's easier to move, either or, and that's why the hybrid developed. All right, so as a core curriculum, we then identified 6 graduate attributes, and these are all translated into the modules that we've developed. So first of all, it's very important for us that the student has a deep understanding on the development and application of simulation. Also, that adult learning theories can be applied within simulation-based experiences. And not only should we be able to apply these simulation theories, but we should also be able to critically appraise our own technologies and the use of these technologies and modalities that we use within our teaching. We should be able to design and implement simulation, and then also to describe the principles of managing a simulation facility. It's one thing being able to teach within the facility, but it's also very important to, like I said, have a holistic approach to simulation. And then lastly, it's very important that a pedagogy of research within the simulation facility is being developed, and hence we also look at research methodologies and approaches that are currently used within the simulation facilities. There are numerous research opportunities within the sim lab, and it's just finding those and looking at them, maybe sometimes just with a different view, to get publications going. Okay, so now I have to move my screen again. Sorry, I'm not used to Zoom. So just a quick overview. So the postgraduate diploma will consist of 7 modules. So it's a 2-year part-time diploma, postgraduate diploma, or a 1-year full-time postgraduate diploma. So module 1 looks at the history of simulation, and you'll see that I've just listed some of the units that will be covered within each of the modules. So the introduction to simulation module basically focuses on the historical development of simulation as an activity or a tool that will lead to the application of this field in health sciences education. So it's fundamental that the student will engage with the knowledge and the history of simulation. So you can see that the units in this module will speak directly to that. So it is also important that it becomes an educational competence from the first module. Sorry, let me just put my phone on silent there. The next module looks at adult learning and simulation pedagogy. So this module is also one of the bigger modules, so it's a 24-credit module. So it will assist the learner in understanding adult learnings and simulation in the application in their own teaching. And it will also provide a theoretical framework and the foundation for the application of simulation within their own course. So it will really help the student or the enrolled person to understand how they teach and why they chose that particular teaching framework. Then if we look at module 3, this is now where most of the fun starts. So this is the simulation technologies and modalities. And I'm sure that all of you will agree with me that this is an ever-changing dimension. There's always something new. And I mean, even if we just look at what Allison presented now, that's already something else that we can look at. So the simulation technology and modality module will focus on the contemporary technologies and current simulation modalities. So here, it's very important that, let's say, for instance, you've identified the lecture unit that you would like to convert into a simulation type module. It's important that you pick the right technologies. And if you don't know what there is or how to use them, it would be quite difficult to do so. Module 4, we then look at the simulation, clinical simulation and instructional design. So how do we design from the get-go right to the end? And it's very important here that we look at ethics and etiquette in simulation and also the principles of simulation design. So here we are starting to construct our own design experiences, and it's the appropriate application of those. So now we've identified a learning pedagogy that speaks to our teaching style, and now we have to implement that appropriately within our own teaching. Then module 5, as mentioned previously, will then be simulation management or the facility management and the structure thereof. So if a university does not have a fully fledged simulation laboratory, this module will not only help the student to identify funding, but it will also help students with already simulation laboratories that can maybe take that to the next level. Then we've got simulation and research, and I think this is probably the module that I'm the most excited about, because here we want to critically appraise research within the simulation environment. This module will also provide the student with the ability to meaningfully integrate current evidence-based informed practices into their own teaching, similarly to what Allison just shared with us now. And then lastly is the simulation portfolio. So here the student will implement, design, and facilitate, like I said, sorry, there's a little bit of a, yeah, my English is slightly gone this morning, but here the student will do a portfolio that will showcase what they've learned through all the other modules. They will design, implement, and assess, sorry, the word was gone, assess their own simulation application and approach with student feedback. So you'll get a whole holistic overview of simulation. And by the time that you're done with this course, your module will already be implemented. So the intake timelines, just to finish off. So we are foreseeing that, oh, that's wrong. So we're not taking locally in this year, it's 2022. And then we're hopefully foreseeing to take international applicants 2023. We are very excited about almost completing this project that's been going for quite some time. And yes, so if there's any questions, I'll happily answer now. Thank you.
Thank you, Karien. Can you just stop sharing for a second?
I can. There we go.
Super. Thank you, Karien, for that breakdown and that presentation. Colleagues, I must just say that all great ideas only remain ideas unless you have people that are willing to really put in the hours and the effort. And I think with regards to this development of this postgraduate diploma, Karien, I think from my side, we appreciate your hard work and your commitment. And I think the nice thing about this is that we did recognize, even before the Glasgow meeting, that although simulation was being more and more used, there wasn't actually a credible niche for an educator that was a simulationist and an expert in simulation. And part of claiming such a position in academia or anywhere is to actually have some form of credibility from a qualification perspective. So I'm quite excited by this. I'm in fact quite tempted to even consider enrolling for this. The nice thing about this program is that it's completely online with a portfolio that would be submitted near the end. And I think this is a program which will go from strength to strength. We look forward to hearing from the pilot, how the pilot went. We're testing out the program and the online technologies. But as Karien said, in 2023, we would be looking for our first group of international role players enrolling from the U21 network. So yeah, I'm not sure if anyone else has a query or comment at this stage. Okay.
Just a
Allison,
commendation, yeah, just a congratulations to the team that how beautifully matured that program has become with the pedagogy and the curriculum. So thank you for flying the flag. And I agree, Craig, maybe we can be study buddies so we can enroll together.
Yes, I think that's it sounds like a wonderful program, and I think that the pilot will iron out any of the little gremlins that will always be there. But I really do look forward to this as a way of really bringing the international simulation colleagues and groups together. And it will be fun, yes. I'll hold you to that. Okay.
And maybe if I can just add, Craig, on that note, I think apart from just bringing everyone together, I think it really has the possibility to strengthen a research network within simulation. And I think that's something that we have to really build on.
No, for sure. All right, well, thank you so much then, Karien. And then I'm going to then move without further ado to Andrew. And Andrew's going to talk to us a little bit about something which I actually presented at U21, but I forget now. I'm becoming old now. I can't remember which meeting. It could have been in China even. And I think it was a discussion we had about simulation and assessment during simulation. And I know that Andrew has really been doing some brilliant work on how we develop the SATLAB tool to limit assessor bias. So over to you, Andrew.
Thanks, Craig. So I'm Andrew Makkink from the University of Johannesburg. I'm just going to be talking a little bit about the update to the simulation assessment tool, limiting assessment bias, or the SATLAB. So what you can expect is, I'm just going to quickly go through some global rating scale scores versus checklist debate, because this is often where SATLAB finds its origins. Then a little bit about SATLAB, some provisional data. We're busy doing quite a bit of research at the moment. How it works currently, it's a flow diagram, and it just shows some of why it needs to change, some of the limitations, and then the future in a short conclusion. So global rating scales and checklists are kind of either one or the other, it seems. So global rating scales generally tend to be nuanced. In other words, the person using the global rating scale has their own personal biases. It generates a percentage, and the perception is often that there's a lack of detail related to how the percentage came about. There's sometimes an incongruency in expectations. In other words, what the person who taught the students thought should be assessed and what the person who did the assessing actually assessed. There's the potential for basing a final result on one specific action or omission, which may or may not actually be significant within the context of the patient. Some arguments say that global rating scales or global rating scores are more reliable and valid than checklists, but obviously there's a bit of disagreement about that. And very often the criticism from students is there really isn't much guidance as to what they did right or wrong from a percentage perspective. From a checklist perspective, there's a perception that they are more objective and therefore they're more reliable, but there's quite a lot of disagreement about that. You'll notice that there's a lot of disagreement about many things in simulation. And there's a perception that there's more of a consistent reliability. Again, there's disagreement. Checklists have shown low sensitivity to increasing levels of expertise. And there's a risk of trivializing steps by rewarding thoroughness rather than clinical competence. I have my own term that I use. I call it tick box simulation, where a student ticks all the boxes, but unfortunately has no idea what's going on. But because they ticked all the boxes, they end up passing. Checklists are limited in healthcare because we have both technical and non-technical elements. And most checklists are generally binary. In other words, they a yes or a no, which in its own can be a bit of a limitation. So what is SATLAB? Karien also showed this picture. SATLAB has actually been described in this Health Sciences Group document. And what SATLAB actually does is it uses a hybrid global rating score checklist model, where we actually break down the SIMs into reasonably measurable competencies. So a SIM is made up of a number of competencies that are determined by the assessor or the marker. And each competency is described in detail using a 6-point sliding scale that describes these. So it starts at best practice and goes all the way down to where there's significant harm caused. And each of these within that checklist is described in detail. The competencies are assigned a percentage, and this will all become clear now when I show, denoting their relative importance within the context of the simulation. It's important to realize that depending on the simulation, certain things become more or less important. Each competency outcome descriptor is assessed individually and contributes to the final mark. And then there's a global rating scale that provides a global perception. The provisional data that we have at the moment suggests that students and academic staff have positive perceptions of SATLAB. We're busy doing quite a big study at the moment, and it's showing good to excellent inter-rater agreement when using between the competency outcome descriptors, and excellent agreement between the calculated final weighted mark, the perception mark, and the mean result. So it all sounds really good, but the current process is somewhat tedious, as you'll see in the flow chart that I'm going to give now. And perhaps the biggest challenge here is that there's no community of access or community knowledge pool. In other words, if I create a sim, the only people who get to see it are the people who I actually send it to. So how does it work? It's easier to explain it by steps. So step one is compiling the simulation. This is pretty much stock standard stuff where the person who is setting the sim would decide on the patient, give some patient variables. And this is usually done by the subject lead or the facilitator or the examiner with whatever role you would like them to assume. And this is normally done in Word or some other kind of word processing document. The competency outcome descriptors that link to the sim are then compiled, again by the same person. And this is normally done in Word and potentially something like Excel to organize the data. This is an example of a competency outcome descriptor, and this would be specifically for an extremity fracture management. And you would see that all this talks to is actually managing the fracture. It doesn't talk to patient assessment. So this would be the competency outcome descriptor for the extremity fracture management. And if you look at the top, you'll see that there's a best practice, a competent, and not yet competent, omitted, some harm caused, and significant harm caused. You'll also notice in this particular sim that a lot is left up to the actual marker, because the level of harm in this scenario can be quite varied. Each of these, the 6-point scale, so a best practice, which is a 3, would be 3 out of 3, and that would count 100% for this particular competency outcome descriptor. Once those are done, it gets sent out for pre-assessment, moderation, and weighting, and these are members of our expert panel, and this is done by Word, Excel, and email. What happens is, if you look at subject expert 1, each person decides on a percentage for each of the competency outcome descriptors. And you would see here in a fracture, you would assume that the two most important things are analgesia and extremity fracture management. And you would see that those are the two, if you look at the mean, those are the two heavily weighted sections. This is emailed to the panel members, they complete it and they email it back, and then it's input and calculated by the examiner. Obviously, the challenge is when people don't read the emails or don't send the emails back, it starts to become a little bit of a nightmare. Then any changes that are made by the moderation panel are approved, and these are then finalized by the examiner. Again, we're using Word and Excel, and to receive them, we use email. Now, the conducting of the actual assessment where the student comes in and does the sim. Unfortunately, the way it is at the moment, it is still paper-based, and a marker will use a document similar to this. They will have a copy of the competency outcome descriptors as well as the simulation, and they will then make their judgment whether it's a 3, a 2.5, a 2, a 1. And right at the end, at the bottom, they have then make their final perception mark. This is then manually captured into Excel by the examiner. And where a person gives a 1, a 0, or negative mark, this is then written down on a piece of paper like this, which again, if needs be, is captured by the examiner into some form of Excel spreadsheet or Word document for the student. As you can see that it's actually quite a lot of manual work for the examiner and everyone involved. Once that's done, there's a result calculation and where necessary moderation. Again, this is Excel and paper-based. This is an example of what the Excel sheet looks like. Obviously, this is based on quite a lot of formulas and background things that are quite difficult if one is not, I use the word good in Excel lightly, but good in Excel. So the weightings, which is the red column, those are what would have been drawn from the competency outcome descriptor weightings from the expert panel. B1 is assessor 1's marks. C1 is, so if you look at mark 1 is 2 out of 3 times 10%, which will give you 6.7%. So for this section, the student got 6.7%. If we add all of those together, we end up getting the 91.1 at the bottom in purple. The 92 is the perception mark that the student gave, that the marker gave. And then we also calculate the mean mark here, which was 80.6. The mean mark between the two assessors is then 87.8. And that is the mark we use along with the perception mark that was awarded to the student. Then we release the feedback, the results and the feedback, and the student, apart from getting their final result, will then get something that looks like this. And the average mark out of 3 is the mean of the two markers mark out of 3. So this was a 2.5, and that translates 2.5 out of 3 translates to 83% for that particular component. And they are then in the competence stage. We have 4 competency stages. You'll notice in introduction and patient communication, the student got a 58. That is the advancing stage. And then a 42 is the developing stage. And the feedback is really based, again, in Excel from formulas, is then provided to the student. You can see that these are quite time consuming. They are labor intensive. They require multiple platforms. We password protect our documents. So it's a challenge changing passwords, and perhaps more difficult than changing passwords is remembering the passwords. Considering that we normally run 5 sims a year, sometimes 10 in a group, so it becomes quite tedious. The process of emailing and re-emailing, the potential for erroneous capturing, and again, perhaps the biggest limitation is the limited access and our knowledge community. So into the future is now. Because funding's been secured to develop SATLAB into an application, this will mean that the complex flow requiring multiple platforms is now hosted in a one-stop shop. The subject leads, which will be the person who really is in charge of the module, will be able to determine who does what. They will be able to determine rights. They will be able to access a mainframe database with a number of sims. They will be able to contribute to that database. All processes will be automated and role-specific. Reminders will be sent automatically. For me, the biggest thing is we'll have a communal database, which will exist for knowledge sharing and interaction. And future developments are also planned to include a more interactive platform where students will be able to engage with SATLAB real time during classroom activities and using SATLAB exactly as it would be used in an assessment. And that in our mind also helps to make them a little bit less nervous and a little bit less intimidated. So in conclusion, 4 hours helping revolutionize simulation with better Makkink fidelity and virtual reality. And I think some of the stuff that was spoken about a little bit earlier, really, that Allison spoke about, we don't necessarily need these high fidelity mannequins in virtual reality just to help us revolutionize simulation. Administration of simulation, which is probably the biggest time consumer, can now also start moving into the 4IR domain, which is really important. And the SATLAB application is a potential step forward, specifically from simulation assessment administration perspective. And then for anyone who's interested, there are my details. Thanks very much, Craig.
Thanks, Andrew. And maybe if I can also say that, I think all of us as health science educators, we do appreciate and understand the blurred line, but there is a line still between teaching and learning and assessment, those 3 things. And I think using a simulation to assess clinical competence has normally drawn a lot of attention, and rightfully so. And you will have students that say, but I only did it this way in the sim. I'm actually much better in the hospital or at the bedside. And I think that, that's a natural pedagogical approach to being assessed. But I must say that I can see that through the work of Andrew and through the implementation of the pilot, SATLAB, which Andrew, I'm not sure whether you said it, but SATLAB actually stands for Simulation Assessment Tool Limiting Assessor Bias. And I think through that, we have dealt with a lot more comfort from students to know that if my simulation mark was 56, this is actually how I got to 56, as opposed to whether or not I pleased the assessor on the day, or whether I did what the assessor feels they would have done if they were treating the patient. So I think this is an excellent project, and it's unfolding, and I'm very glad to say Andrew has received some more funding, and we will definitely be sharing this if and when, shall I say when, not if, the application is developed. We do have the intention of making it available as an app for colleagues across the network. So yeah. But I think, thanks, Andrew. I think that summarizes the last of our presentations. I don't know if there's anyone that's online at the moment who has a particular question or query for Andrew. No. Okay. Well, thank you then, colleagues. I think that from my side, as the chair of the simulation interest group, and probably my first virtual meeting, I would like to end off by saying it would have been wonderful to have a cup of tea and coffee and a sandwich with all of you. But times are what they are. Again, to end off, thank you to Ricardo, Elena, all of the people from the host institution. You really have made this seamless, professional, and you stayed awake. I'm sure you're going to have a good rest later on once the time zones return to normal. And Allison, to you for staying up so late. But thank you, colleagues. Thank you very much. Yeah.
And thank you to you, Craig, for chairing. It's great to have this collaboration extended, and a real pleasure to be part of the session. Thanks to everyone.
Thank you, Allison. Colleagues, we will touch sides again as the core members of the grouping. We'll within the next month or so, we'll have a discussion about the way forward and where we go to from here. Thanks. I think, Ricardo, am I handing back over to you then for the next session?
Yes, Craig. Are you going to have another presentation from Elena, or that's it?
Yeah. Is there any, Elena, are there more presentations? Are you going to wrap up for us, or is there anything else, or are we finished? Sorry, Elena, your sound is not working. Is it only me? Can you guys hear Elena?
I have no sound.
Not yet.
Can you hear me?
Yes,
Yes.
Elena, we can hear you now.
Thank you. Okay. Oh, well, Ricardo, can you please, like a minute, please? Well, I am Elena Ríos, the National Director of Clinical Simulation Center at Tecnológico de Monterrey. Welcome, and I am very happy to share this time with you. I'm a doctor and professor at our school, and I love clinical simulation like you, because I consider it to be the most experiential learning strategy that can improve clinical safety. I am secretary of LASIK, Latin American Federation of Clinical Simulation and Patient Safety, and I extend a cordial greeting from there too. Our center provides training both to students of the different health careers and to residents of the different postgraduates of our hospitals, as well as continuous training to the personnel of the Tec hospitals, and continuing education too. And well, the pandemic made us reinvent the center and our way of working, using various strategies such as a telesimulation like Allison or hybrid simulation, but we have not left face-to-face assistance through the protocol, biosecure protocol. So I am very glad to share this video with all of you to present you the heart of our school, and well, enjoy it. Thank you. Ricardo, please, can you help me with the video, please?
The Clinical Simulation Center of the School of Medicine and Health Sciences is an innovative and realistic venue, providing controlled, safe academic environments for teaching and training in diverse health professions and clinical specialties, including training in the areas of hospital care. We have clinical simulation centers in 4 locations: Monterrey, Guadalajara, Mexico City, and Chihuahua, all of them with the same purpose: to provide our students and health professionals opportunities to broaden their knowledge and practical experience. At the Monterrey Clinical Simulation Center, located with the Health Innovation and Transfer Center, we find the workshop multi-purpose area. We're teaching activities requiring larger participant capacity, such as CPR workshops or the workshop on suturing biological tissues are held. This area can also be converted into multiple physical examination stations, operating rooms, and the like. We have 5 cubicles for various clinical activities, one of which simulates a hospital room, where simulated outpatients are interviewed. Additionally, to fortify an array of clinical care competencies, we offer office and procedure cubicles furnished with a wide variety of low and medium fidelity mannequins, allowing trainees to expand their procedural skills, such as diverse proofs and other exploratory examinations of the body. At the Clinical Simulation Center, students and health professionals live a transformative educational experience thanks to our highly realistic simulators, which can be programmed to simulate diverse pathologies and allow trainees to confront an array of clinical scenarios, such as adult emergency care area, specializing in the management of adult emergency patients, consisting of 3 service stations equipped with high-fidelity robotic mannequins. Pediatric emergency care area, specializing in the emergency treatment of pediatric patients, equipped with simulator mannequins of both school-age children and infants. Gynecology and obstetrics care area, a space for simulating comprehensive management and care of pregnancies, equipped with simulator mannequins on which trainees can practice activities as diverse as palpating gravid uterus, collecting pap smears, as well as performing gynecological and breast exams. To reinforce trainee skills in both delivery and care of newborns, the area provides robotic simulators of normal pregnancies and those exhibiting complications during labor. These 3 areas are equipped with Gesell cameras, allowing teachers or tutors to observe activities of the students, hence enhancing their self-assurance. Likewise, each area is furnished with clinical equipment, fixtures, and medical devices and supplies to ensure both physical and contingent realism needed to provide trainees the optimal educational experience possible. In response to the current pandemic, we have redesigned processes and modified logistics associated with the use of physical space and daily operations. These changes involve both patient capacity restrictions and furniture layout, and serve to minimize the risk of propagating the contagion, while also guaranteeing academic continuity of this essential practical component of healthcare training.
Thanks for that. That was my apologies. I had actually forgotten about that presentation, but I'm glad I was reminded. It certainly is a wonderful facility, and it's just such a pity now. I'm sitting back again. I keep moaning and moaning like a small child about the travel, but it's such a pity we couldn't have been there to actually do a tour of the facility. But thank you, Elena, for sharing with us the facility. I see lots of similarities between what you're doing there and what we're doing here. And I think once things get back to normal, we will definitely like to invite you to come and see our simulation facility here in South Africa.
Thank you, Craig. Thank you. Thank you.
Okay, colleagues, help me out here. Is there something else I'm missing, or are we finished with the session for the simulation group?
We're already finished, Craig. Thank you so much for your time, for all the information that you have shared with us. And we will be back in about 1 hour with our next conference. Thank you so much for your time and for being here with us this morning.
Thank you, colleagues, and please stay safe. Stay safe. Bye.
Congratulations and have a nice
everybody.
day.
Well done, and thank you, everybody. I might see some of you at the next IPE forum. I'll be there. So
See you in a few minutes, Allison. Thank you so much.
I'll see you in a few minutes, Ricardo. Thank you, everybody. Take care.
Thank you, everybody. I will return you to the waiting room. Remember to be connected in about 1 hour so we can begin on time with our next presentation. Thank you so much.